Welcome everybody to this week's edition of the Extracellular Vesicle Club. This event is a collaboration of the International Society for Extracellular Vesicles and Socrates this week. So we've been doing a once per month Socrates collaboration. And this time we have Wei Seong Toh in the presenter's chair instead of the moderator's chair. So yeah. Thanks very much for presenting today. And I'm going to hand this over to co-moderator Minh, who's going to introduce Wei Seong. And I just want to ask everybody to please remember to put your comments and questions in the chat box. And we will allow you to unmute at the end of Wei Seong's presentation for some good discussion. So Minh, I'd like to hand it over to you. Thank you so much for moderating today. And please introduce our speaker.
Thank you so much, Ken. It's a pleasure to introduce Associate Professor Wei Seong Toh from National University of Singapore. And it's special today because it's a Teacher Day in Singapore. Congratulations and happy Teacher Days to Wei Seong and all the teachers here. Ken as well, you are professors. So it's a special day to honor teacher, and it's a pleasure for us to hear from Wei Seong about his research. Also, that he has trained many students at NUS for the research on extracellular vesicles. And it's a good continuation of our discussion on mesenchymal stem cell EVs, continues from what Sagan discussed last time with us. So we look forward to Wei Seong talk about his research, especially the research that he has done on the therapeutic effect of these vesicles in treating bone diseases. And I'd like to pass it to Wei Seong now, and I'll continue at the end with the question. Any question that you have for Wei Seong, please put in the chat box.
Hi everyone, I'm Wei Seong Toh from NUS. Thank you very much for the opportunity to share our research progress in this EVClub seminar series. So to start off, let me begin with the clinical problem. The clinical problem of cartilage injury, often caused by trauma or excessive activity. And if poorly treated, cartilage injury may develop into osteoarthritis or OA, a chronic degenerative joint disease associated with pain and degradation of the cartilage and subchondral bone. And not only affects the knee joints, but also other smaller joints, such as the temporomandibular joint or the Tmjoa. And with increasing obesity and aging, the prevalence of OA is also increasing. Current treatments of OA are mainly symptomatic, and there's a lack of effective disease-modifying therapies. Consequently, total joint replacement is the only surgical solution at the end stage of the disease. Among the innovative therapies evaluated for joint repair, mesenchymal stem cells, or the MSCs, represent the most tested cell type in regenerative medicine against several injury and disease indications, with over 1,000 clinical trials, including that for OA. Although it was originally thought that MSCs differentiate and replace the damaged tissues, it is now well accepted that these cells mediate tissue repair through secretions of trophic factors, particularly the extracellular vesicles or the EVs. Among the EVs, we are particularly interested in the small EVs of size range 50 to 200 nanometer. In collaboration with Saikyang Lim from A-Star, we derived the small EVs from a standardized human MSC9 for our studies. These small EV preparations have been previously shown to contain exosomes with lipid membranes composed of cholesterol, sphingomyelin, and phosphatidylcholine, and express exosome-associated markers including ALEX, TSG101, and CD81. These MSC-EVs also express CD73 and ecto-5 nucleotidase, and as we all know, CD73 is also a MSC marker. These MSC-EVs have also been previously profiled to have a rich cargo of proteins and nucleic acids with potent immunomodulatory and tissue regenerative properties. And for this presentation, I will use the term exosome as synonymous with small EVs. So to test the efficacy of MSC exosomes for osteochondral repair, we first created critical size osteochondral defects on the tracheal groove of the rats. Intra-articular injection of 100 microgram exosome or equivalent volume of PBS were then given right after the surgery. and subsequently weekly for up to 12 weeks. Tissue were then harvested at 2, 6, and 12 weeks and subjected to analysis. Our findings show that MSC exosome initiate repair as early as 2 weeks. Microscopically, exosome-treated group show better new tissue formation compared to the PBS control group. Histologically, we observe improved cartilage and subchondral bone regeneration with enhanced surface regularity, matrix deposition, and integration with the adjacent host cartilage in the exosome-treated group. And this was consistent with better histological scoring results observed with exosome treatment. We further confirmed by IHC that exosome regenerated tissues were high-night cartilage with high collagen 2 and low collagen 1 expression. The chondrocytes in the exosome repair tissues also show distinct pericellular staining for collagen 6. To elucidate the possible underlying mechanisms, we stained the samples for PCNA for proliferating cells and CCP3 for apoptotic cells. And we observed that exosome-treated group display significant increase in PCNA proliferating cells in the cartilage tissue and overlying synovium. This was accompanied by a decrease in CCP3 apoptotic cells in the cartilage. These findings together suggest that MSC exosome enhance cell proliferation and attenuate apoptosis to promote osteochondral repair. Next, we investigated the distribution of the anti-inflammatory CD163 M2 macrophages and pro-inflammatory CD86 M1 macrophages during osteochondral repair. We observe a high infiltration of M2 macrophages in the cartilage and overlying synovium as early as 2 weeks, followed by a decrease over time. Importantly, across all time points, M2 macrophages remain consistently higher in the exosome treatment group than in the control group. In contrast to M2 macrophages, CD86 M1 macrophages were reduced in both cartilage and overlying synovium in the exosome treatment group as compared to the control group. Consistently, lower levels of M1-associated cytokines, IL-1 beta and TNF-alpha were observed in the synovium fluid in the exosome treatment group. Next, we investigated the effects of MSC exosomes in a rat model of Tmjoa. To create this animal model, we injected 0.5 milligram monoethyl acetate MIA to the TMJ to induce Tmjoa for over 2 weeks. The animals then received weekly intraarticular injections of 100 microgram exosome or equal volume of PBS up to 8 weeks. Pain response was then measured every week. At 2, 4, and 8 weeks post-treatment, the animals were sacrificed and the TMJ harvested for analysis. For pain behavior analysis by measurement of the head withdrawal threshold, we observed that the pain was progressively reduced to baseline with the exosome treatment and was similar to the sham group from week 5. In contrast, the PBS control group showed minimum pain improvement. Histologically, the exosome-treated group at 8 weeks showed TMJ structural restoration with improvement in overall condylar height, cartilage thickness, cellularity, matrix deposition, and subchondral bone integrity that were comparable to that of the sham group and closely resemble that of the naive TMJ. Consistently, micro-CT analysis also show subchondral bone restoration with exosome treatment. Consistent with the observed effect of MSC exosome in promoting TMJ structural repair, the percentage of PCNA proliferating cells were consistently higher in the exosome-treated group than in the PBS control group. On the contrary, the percentage of CCP3 apoptotic cells was significantly lower in the exosome-treated group and was comparable to the sham group at all 3 time points. Next, we also performed staining for IL-1 beta and INOS for inflammation and oxidative stress. We observed that relative to the PBS group, the percentage of IL-1 beta positive cells in the exosome group was initially lower at 2 weeks before peaking at 4 weeks to a similar level as the PBS group. And by 8 weeks, there were no significant differences among the 3 groups. On the other hand, the exosome-treated group had lower percentage of INOS positive cells, which was similar to that of the sham group at all 3 time points. Together, our in vivo results for the OA model demonstrated that MSC exosome reduced TMJ degeneration by suppressing pain and promoting overall TMJ structural repair. Our findings also show that MSC exosomes enhance cell proliferation and attenuate apoptosis while suppressing inflammation and oxidative stress to attenuate OA. Based on these observations gathered from the rat models of osteochondral defect and OA, we propose that MSC exosomes work through a multifaceted mechanism of action in immunomodulation, anti-apoptosis, proliferation, and matrix synthesis. And this multifaceted MOA could be attributed to the rich cargoes of proteins, lipids, and nucleic acids carried by the MSC exosomes. To address some of the in vivo observations, we examined the effects of MSC exosomes on primary rat chondrocytes in vitro. We observed that MSC exosomes were rapidly uptake by the cells. We further tested 1, 5, and 10 microgram of exosomes and observed that MSC exosome enhanced chondrocyte migration, metabolic activity, and proliferation in a dose-dependent manner, as gap matrix synthesis was also increased with exosome treatment. These observations were supported by our gene expression results, where genes associated with survival, proliferation, and cartilage matrix synthesis were upregulated with exosome treatment. Cell response to MSC exosomes in the presence of inflammation in OA can be quite different. Therefore, we further tested the effect of MSC exosomes in our in vitro chondrocyte OA model. In this model, chondrocytes were seeded as pellets and stimulated with IL-1 beta for 24 hours before exosome treatment for another 6, 24, and 48 hours. Cell and supernatant samples were then collected for analysis. Our results show that IL-1 beta treatment decreased S-gap matrix synthesis along with increased nitric oxide and MMP13 production. However, these effects of IL-1 beta were reversed by MSC exosome treatment. Notably, MSC exosomes were able to enhance S-gap matrix synthesis impeded by IL-1 beta while suppressing IL-1 beta induced nitric oxide and MMP13 production in a dose-dependent manner. We previously reported that MSC exosome expressed CD73 and ecto-5 nucleotidase enzyme that converts extracellular AMP to adenosine, which in turn interacts with adenosine receptors to activate pro-survival AKT and ERK signaling. To elucidate the role of exosome CD73 in mediating AKT and ERK phosphorylation, we perform co-treatment of chondrocytes with exosomes in the absence and presence of AMP-CP, which is a CD73 inhibitor, and theophylline, which is a non-selective inhibitor of adenosine receptors. We observed that in the presence of AMP-CP, there were decreased AKT and ERK phosphorylation. Similar suppression in AKT and ERK phosphorylation was observed with theophylline inhibition of the adenosine receptors. From this result, we can confirm that MSC exosomes promote AKT and ERK phosphorylation in chondrocytes through the exosome CD73 activity. To further understand the roles of AKT and ERK, we investigated the effects of MSC exosomes on chondrocyte functions in the presence of vermentin and U0126, which are the AKT and ERK inhibitors. Our results show that MSC exosome induced rapid AKT and ERK phosphorylation, but these were abolished respectively with vermentin and U0126. Functionally, MSC exosome enhanced chondrocyte migration, but this was suppressed by AKT inhibition and a lesser extent by ERK inhibition. Similarly, cell proliferation enhanced by MSC exosomes was significantly reduced by AKT inhibition, but not by ERK inhibition. For matrix synthesis, there were no notable differences with or without AKT or ERK inhibition. Next, we look at the roles of AKT and ERK in mediating the effects of MSC exosomes on chondrocytes under inflammation in our in vitro chondrocyte OA model. In the presence of AKT inhibition by vermentin, exosome-mediated AKT phosphorylation in IL-1 beta-treated chondrocytes was attenuated. Functionally, exosome treatment increased S-gap matrix synthesis and decreased nitric oxide and MMP13 production in IL-1 beta-treated cells, but these effects were reversed by AKT inhibition. Similarly, in the presence of ERK inhibition by U0126, exosome-mediated ERK phosphorylation in IL-1 beta-treated chondrocytes was attenuated. Functionally, exosome treatment increased S-gap matrix synthesis and decreased nitric oxide and MMP13 production in IL-1 beta treated cells, but these effects were reversed by ERK inhibition. So far, we have shown that weekly injections of MSC exosomes were efficacious in promoting osteochondral regeneration in rats. However, weekly injections may not be clinically feasible. We propose that hyaluronic acid, or HA, that is commonly used as viscosupplementation could complement the efficacy of MSC exosomes to reduce the number of injections needed for cartilage repair. So we created a rabbit osteochondral defect model where we tested 3 intra-articular injections of 200 microgram exosomes with HA, or HA alone administered immediately after the surgery, and thereafter at 7 and 14 days post-surgery. Tissue were then harvested at 6 and 12 weeks for analysis. As evident by the gross appearance and ICRS macroscopic scoring, exosome HA combination was efficacious in enhancing the gross appearance of cartilage repair compared to HA alone at both 6 and 12 weeks. By the end of 12 weeks, when we performed the histology, exosome HA treated defects show new cartilage that display good surface regularity, high cellularity, and rich matrix deposition of SGAT stained by toluene blue. In contrast, HA treated defects show mostly fibrous tissue and had minimum SGAT deposition. These observations were also reflected in our OGSCO scoring and semi-quantitative analysis of toluene blue stain areas, with exosome HA group having significantly better scores and higher area matrix deposition. We also confirmed by IHC that exosome HA repair tissues were mainly hyaline cartilage with high collagen 2 and low collagen 1 expression. Collectively, these results show that exosome HA combination administered at a clinically acceptable frequency of 3 intra-articular injections can promote sustained cartilage repair over 12 weeks. To enable clinical translation, we collaborated with Professor James Hui, an orthopedic surgeon at NUHS, and further validated the safety and efficacy of MSC exosomes in a clinically relevant porcine model. In this study, bilateral osteochondral defects measuring 6 mm diameter and 1 mm depth was surgically created on the weight-bearing area of the medial femoral condyles in 12 micropeaks. Immediately after surgery and at day 8 and 15 post-surgery, 6 peaks in exosome HA group received sequential administration of 1 milligram exosome in 1 ml of PBS, followed by 1 ml of HA, whereas the other 6 peaks in the HA group received 1 ml of PBS, followed by 1 ml of HA. Except for MRI performed on day 15, 2 and 4 months, macroscopic, histological, and micro-CT assessment were performed at 4 months. As shown here, these are the representative MRI images with the medium scores. All the images were scored using a system that assessed several parameters with a total perfect score of 15. As you can see from the images, exosome HA treated defects show better morphology and had significantly better MRI scores than the HA treated defects at all time points. At 4 months, the peaks were euthanized and the femurs were harvested. It is evident from the gross appearance that exosome HA treated defects show more new tissue filling than the HA treated defects. And ICRS macroscopic scoring that assess the degree of defect repair, integration, and macroscopic appearance further show significantly better subcategory and overall scores in the exosome HA group. Histologically, samples were scored by ICRS2 histological scoring system that assess several parameters and rank accordingly to best, medium, and worst repair. Consistently, exosome HA treated defects had better scores than HA treated defects across all 3 ranks. Consequently, exosome HA treated defects had better overall ICRS2 histological score than the HA treated defects, with significant improvements in parameters including chondrocyte clustering, integration, time mark, and subchondral bone abnormalities. We further performed micro-CT to evaluate subchondral bone regeneration. We analyzed at the region of interest, or the ROI, at the subchondral bone region of the defect. You can see from the images that exosome HA treated defects had greater bone volume and thicker trabecular bone thickness than that of the HA-treated defects, as also indicated in our quantitative results. Next, we perform compressive testing to evaluate the functional mechanical competence of cartilage repair. As shown in the photo, compressive testing was performed on several points on the defect area of the medial femoral condyle, MFC, and lateral femoral condyle, LFC. We observed that relative to HA-treated defects, exosome HA-treated defects had significantly higher Young's moduli and stiffness at all the peripheral points, but not at the defect center. Nevertheless, the values approximated that of the native cartilage of the lateral femoral condyles at all the points. These findings clearly demonstrated that exosome HA treatment promote functional mechanical competence of the repair cartilage. Next, to evaluate the safety profile of MSC exosomes, we perform blood serum analysis of the liver and kidney markers. The levels of these analytes in both exosome HA and HA group were within the healthy reference range as indicated in the gray areas. Except for ALT that was slightly lower than the exosome HA group, both groups had similar levels of the analytes. Since HA is already clinically used and has a well-established safety profile, we can conclude based on these results that MSC exosomes are equally safe. With these, I'd like to conclude my presentation. We have shown that MSC exosomes exert a multifaceted mechanism of action in joint repair. They work by restoring homeostasis to the injured tissues to enable tissue repair and regeneration. Some of these therapeutic activities of MSC exosomes in joint repair could be attributed to CD73-mediated adenosine receptor activation of the pro-survivor, AKT, and ERK signaling pathways. Lastly, we have also shown that MSC exosomes administered with HA at a clinically acceptable frequency of 3 intraarticular injections promote functional osteochondral repair and demonstrate a good safety profile in a clinically relevant porcine model, thus demonstrating a clinically translatable protocol. With this, I end my presentation, and I'd like to thank my team members, collaborators, and funding from the various agencies for their kind support of our work. Thank you very much for your attention, and I'm happy to take any questions. Thank you.
Thank you, Wei Seong. That was a wonderful talk.
Dr. Toh, that's a wonderful talk. Thank you for a very elegant work. Enjoyed your presentation. I had a question regarding your first part of your study. You used 100 microgram exosomes, right?
Yes.
Did you try doing any dose response? Do you really need 100 microgram, or did you perform a dose response study? And what are your thoughts on that?
Yeah, so we have actually done some studies on this. So at least in our hands, right, okay, is that lower concentrations, you might actually need to increase the frequency of the administration. So at least for in our rat model where we perform the weekly injections in our osteochondral defect model, we found that 100 microgram, okay, is the optimum dose to use where we administer at the weekly interval. At the lower concentration, we could see some repair, but it wasn't as good.
I should have 2 questions for you, please. Do you think there is some function of MSC exosomes to promote the monocytes to differentiate into M2 macrophages? Do you think that is possible or not?
Yeah, so we have done some studies on this. Yeah, so we found that MSC exosome have the ability to actually promote the M2 macrophage polarization.
And also, I'm interested in whether there is a difference between the EV fraction and non-EV fraction from your MSC conditioned media.
So what we have done is we isolated, at least my collaborator, we isolated the exosomes, okay, through the size fractionation method. So we have clearly characterized the EVs, okay, according to the size range, and also characterized based on their marker expression. So in terms of the non-EV fractions, okay, there will be, at least in our hands, we have isolated the purified EVs for our studies.
I see. Probably there are some soluble proteins can function as a repair, right?
Yes.
Okay, thank you very much.
Yeah.
Okay.
Thank you.
Right.
Thank you.
Yep.
Regarding the non-EV fashion, do you use any of the flow tool as the control for your study?
So we the exosomes, right, were obtained in collaboration with my collaborator, okay, Sai-Kiang Lim. So as far as I understand, the exosomes the EVs were characterized, and we did not perform experiment with the non-EV fractions.
The question is quite simple. What was the MSC source that you used?
Yeah, so the source of the MSC source, right, was from these immortalized human embryonic stem cell derived MSC9 that we derive standardized source of the EVs for our studies. So it's an immortalized human ESC derived MSC9.
Regarding that, if you use different line of IBS to derive the MSC, do you see different effect? Is there variation?
So that question, right? Okay, I think Sai-Kiang will be a better person to answer that. She has done a very thorough study on the cell source, and I think what she have also found is that the source of the EVs derived from the MSCs, it depends on the donor age of the MSCs. And what we found was that the amount of EVs, depending on the donor age of the MSCs, okay, with an older MSC9, the quantity of the EVs that we could derive would be lesser.
But in terms of function,
the function I have not tested in my hands, yeah. But at least in terms of the quantity, okay, we at least from my understanding is that they have found out that the quantity of the EVs will be lesser if you are deriving it from a older MSC9.
Yeah, thank you. But thank you for the presentation. And I think you have just answered the first question. And my next question is like how you separate these EVs. Which kind of method have you used from the cell culture media?
So we use this size fractionation method.
Size exclusion.
Yeah, size fractionation. Yeah, it's by size exclusion chromatography.
Okay, thank you. And my next question is, how long would it take for EVs to be digested? Would it be digested, or like, I just want to ask like why these effects could be lasting so long inside body? So I mean, how could this work? Is like the EV's cargo inside or I don't know. Thank you.
Okay, so at least in our hands, right? We have tested the EV bioactivity by measurement of their CD73 and CD81 activity. And at least in vitro, we realized that we found that the bioactivity of this EV, they diminish, okay, rapidly within a week. So, but in terms of the in vivo, this bioactivity of the EV, as we know, okay, the EV, once they are administered in vivo, they interact with the cells and they are also rapidly uptake by the cells. And that's where, okay, the therapeutic effects, okay, will be able to take place after that. We did not observe any effect from the decline, okay, the rapid decline of the therapeutic activity as we observed in vitro, okay. And as what I say, okay, once the EVs were being uptake by the cells, they were able to elicit the cell response as we observe.
But like, so you mean the EVs inside the HA will be released from the HA, right? Will it be released outside?
No, so the EV with the HA, okay, the EV will be released, okay, once they are administered into the joint cavity. So in the joint cavity, there will be biodegradation, okay, and so on, that there will be a release of the EV, and the EV will then be interacting with the cells in the joint cavity.
Okay, I think I understand.
Yeah, okay, yeah.
But
so the cells
like,
will be up.
But like, what is the dynamic for the EVs to be released outside the HA to interact with the other cells?
I'm not too sure if I get your question.
Like, is it slowly released or quick released, or like?
Okay. So you're asking about if there's any sustained release of the EVs from the HA. So
yes.
In our hands, we did not actually perform such study, but what we have actually found out was that in combination with the HA, there were synergistic effects of the EVs and the HA on the chondrocyte functions. So that was what we have tested in our lab, and we observed that there was synergistic effect in enhancing the chondrocyte functions.
So you have done the in vitro experiments to test. Because I just want, maybe it could be used in vitro to, like, because now we just supplement the EVs like in high dose once into the cell culture media. So to do the experiment, maybe this HA could be used like to slowly release the EVs and then to have the
so there could be such a possibility, but in our hands, we did not look into the sustained release of the EVs from the HA. But what we have done was that we observed that there was synergistic effect of this combination on the chondrocyte functions.
Thank you.
Yeah, but also, right, again, although we have not done the sustained release experiment, okay, but the HA, as we know, is a very viscous liquid. So we think that, okay, because HA is already used clinically, so we think that this will be a good combination with the exosomes, with the EVs, that because it's viscous, it will be able to localize the EVs in the joint cavity. And by doing that, okay, it helps to sustain the tissue repair.
So you showed that these EVs regulate the macrophages. So apart from macrophages, did you look at any other cell types, immune cell types?
Yeah, so we have done quite a bit of experiments with the macrophages, and at the same time, okay, we are also evaluating the effects of the EVs, the MSC-EVs, on the other immune cell types. But for this work is still currently ongoing. What I could share is that at least in our animal model, we did observe that the MSC-EVs had this effect on modulating other cell types, okay, other immune cell types, such as the Tregs, okay. So currently, this is work ongoing, yeah.
Thank you, Wei Seong. We have a question from Maimona.
So I have a basic question, like, why did you estimate your dose by concentration of proteins and not the number of particles?
Yeah, so you could actually do it either way. So either by the protein concentration or by the number of particles. Yeah, so in our studies, right, okay, we just thought that it would be easier for us to standardize by the protein concentration.
Yeah, because the protein concentration might also reflect the impurities that's in the preparation, right?
Yeah, true. Yes. Yeah, but at least in our hands, right, what we also found is that the source of EVs, okay, they have quite a very reproducible profile in terms of their protein concentrations and also their particle number.
Okay, so I have another question. How did you choose the cells that you produce the cell line from? I mean, were there any specific criteria for this selection?
Okay, so that is a kind of like the hard work of my collaborator that they have derived this MSC9, and they have characterized this 9 to be able to produce these EVs that we have shown, okay, that these EVs have the therapeutic effects on several of the disease indication that we have tested. So it's actually over the years that we actually have built up this data to show that the EVs produced from these cells, they are therapeutic.
Yeah, so from the beginning, they had some functional, properties. That's why they were selected, because as we know that different MSCs will have different functionalities,
Yeah,
right? It's not consistent.
Exactly. Yeah, exactly. So which is why it's very important that once you identify the cell source that you wanted to derive your EVs, you will have to actually log the process of the manufacturing of your EVs so that you can actually get reproducible EVs for your experiments.
Okay, so one last question. Have you observed any adverse effects with high concentrations of EVs?
So we have not actually done a dose escalating study, but in our experience, right, okay, which in our pig model, we have actually went up to 1 milligram of the EVs, and we administer 3 injections over 2 weeks into our pig model. So at least in our hands, we have tested up to 1 milligram in our large animal model and have observed no side effect. So we actually performed the standard analysis on these, where not only when we harvest the femur, okay, we look at if there's any adverse tissue response, and also we harvested the blood serum, where we actually test for the panel of the liver and kidney markers. So you could see from one of my slides that the safety profile, okay, of these endolytes, at least from these endolytes that were measured, they were comparable with the HA, which is already clinically used. And the values that we obtained, okay, from these endolytes, they were within the healthy reference range of the pigs.
Can we have Siglo now? Siglo time?
Okay. Yeah, yes. So the biodistribution. So we currently are working on that, okay, and we hope to be able to share this data later. Yeah. So the biodistribution of the EVs, right, okay, is a challenge in the field. So as we know, right, the current techniques using the lipophilic dyes, okay, they are not able to give us a very accurate readout in terms of the half-life of the EVs and their biodistribution. So clearly, there's a need for better techniques to assess this biodistribution, and currently we are working on that. Okay, so the relevance of the in vitro study, okay, as I have shown, is to really to allow us to probe into the cellular mechanism and also the processes that are modulated by the MSC exosomes. And have you performed studies with MSC-EVs on T cell activities? Yeah, so currently we have not done that, okay, but I remember that my collaborator has done some work on that. But what I could share is that at least from our animal models in the osteoarthritis animal models, we did observe some differences, okay, in terms of the immune cells, okay, mainly on the macrophages and also on these neutrophils that we observe some innate immune responses, the differences. The T cells, right, there would also be some differences if I remember clearly from some of the data that my collaborator has done. Into the specific proteins and RNAs, okay, yeah. So at least myself and also my collaborator, Saikyang, okay, we have this bias towards working on proteins. And in one of our paper that we co-authored together, we did actually discuss this issue that we feel that the proteins, okay, at least in the MSC-EVs, they have this configuration and also the concentration that allow the proteins to be better candidates in eliciting the biological response that we are seeing in our animal studies. So do you think that the effects are mediated upon uptake or interaction of the MSC-EV proteins with surface receptors? So both are possible. So even before entering into the cells, okay, the MSC-EV could actually interact with the receptors, okay, possibly CD73 that I have, through the CD73 that I have mentioned. And upon intake into the cells, okay, that's where the EV will then be releasing their cargo contents, okay, to elicit the necessary biological response. Then the next question is asking about this, the EVs derived from human, okay, and in vivo study. Is there any effect of, okay, so in terms of cross-species immune response against MSC-EV, we did not observe any of these cross-species immune response. So if I understand your question correctly, you are asking if there is any adverse xenogenic immune response from applying these human MSC-EVs in the different animal models. So we have tested in a wide range of animal models. So together with my collaborators, we have tested in a wide range of animal models, ranging from mice to rats to rabbits and even to pigs. We did not observe any of these adverse response from these animals that we have tested. And was asking about to reduce the effect of, so as I say, right, in the wide range of animal models that we have tested, we did not observe any adverse response from
any neutralizing antibody.
No. So we did not do any experiments with the neutralizing antibodies. No, we did not do that.
I just wanted to say thanks so much for sharing this work with us, and thanks to both of you for making sure that we also had a very robust discussion today. All right, well, thanks everybody for joining. Hope you have a good rest of the week, and I look forward to seeing you again soon.